Thank you, Jennifer. Let's see. Okay, so just accepting the recording. So yeah, I'm looking forward to talking to you guys. I've worked with many of you. I appreciate you guys having me in to chat with you guys. I decided on a topic that I think you guys are all kind of familiar with in terms of outpatient management of heart failure, but there's been a kind of a variety of updates in the literature in the last 1 to 2 years. So I wanted to go over some of those things, then kind of review some of the new therapies and evidence for those therapies throughout the next hour. In terms of questions and things, feel free to just interrupt me, raise your hand, put a question in the chat, or I'll kind of like answer questions at the end. And as Jennifer was saying, I've been here for about 5 years, and like I've been at a variety of training programs across the country, and really got to see our heart failure and transplant program grow pretty remarkably in the last 4 or 5 years. We're now kind of a top 10 transplant program in terms of size, and probably in the top in terms of outcomes in the state. And so, we will definitely share patients along the way. Okay, but to go to our topic here, updates and outpatient management of heart failure. So we are going to um, cover a few topics. We're going to talk about the management of heart failure with reduced ejection fraction, which there has been new guidelines that have not only defined or redefined the definition of heart failure and how to diagnose it, but also just we'll go over some of the newer classification systems and how to divide and categorize heart failure with reduced ejection fraction. We'll then go on to kind of chronic therapy, so talking about your guideline-directed medical therapy, and then talk about some of the devices and the guidelines for our use of those. And then we'll finally kind of conclude on HFrEF with the how to initiate and kind of layer therapies according to the latest guidelines, and then when to kind of think about advanced therapy, things like heart transplant and LVADs in the process. And then lastly, just a couple of slides because the newest guidelines have kind of new kind of therapies for heart failure with preserved ejection fraction, as well as heart failure with mid-range ejection fraction that was new. And you'll notice the kind of reference here. This is going to be the reference throughout the whole talk, which is the 2022 AHA-ACC guidelines for the management of heart failure. So if you guys have a moment, we'll kind of talk about many of the key points, but if you have a moment, it's a really great document that kind of goes into a lot of depth on how they got to these recommendation decisions. So in terms of the new definition for heart failure, so this came out last year, and it was a universal definition kind of across all heart failure societies, including the Japanese Heart Failure Society. And it defined heart failure as a clinical syndrome with symptoms or signs caused by structural or functional cardiac abnormalities, which a functional cardiac abnormality, as defined by this document, was determined as an ejection fraction less than 50%, any cardiac chamber enlargement, and then certain kind of echocardiographic parameters, such as an E to E prime of greater than 15, hypertrophy seen on imaging, or moderate to severe valvular obstructive or regurgitant lesions. And it's corroborated by an elevated natriuretic peptide level and or objective evidence of pulmonary or systemic congestion. And we'll go over some of those BNP levels in a moment. In terms of ACC-AHA stage, so in terms of heart failure classification, so in the last like 5 or 6 years, they've really tried to make it known that heart failure should be considered a chronic illness, similar to many of the other chronic illnesses such as CKD, certain malignancies where they have staging systems, and similar to those stages, as you go forward through a stage, you never go backwards. So whenever you progress to, for example, stage C, even if you are no longer symptomatic, you never go backwards to stage B or stage A. And it'll kind of make sense when you go through the definitions of that. So stage A really means you're at risk for heart failure. So you've had either hypertension being the most common risk factor across our population, but you have diabetes, CAD, obesity, whether you've been exposed to anthracyclines or have just a genetic variant or family history. Those are all people that are at risk for heart failure greater than the kind of general population. Stage B heart failure is people with structural heart disease or an evidence of increased filling pressures, but no current or previous symptoms or signs of heart failure. So people that really just have imaging or lab tests that are consistent with heart kind of pre-heart failure, they call it, or preclinical heart failure, before they progress to stage C heart failure, which is symptomatic heart failure. So this kind of, as it sounds, people with current or previous symptoms. And lastly, stage D is people that really have really marked symptoms that are defined as advanced heart failure, where they have, really limitations on their quality of life, recurrent hospitalizations, and despite kind of the best attempts at therapy. The system that you're probably most familiar with is the NYHA class, functional classification system, which has been around for a couple of decades. And that categorizes people, as it sounds, with their functional class, so basically their activity limitations. And it goes from class 1 to class 4. Class 1 are people with no significant functional limitations. They can do kind of ordinary activity without any symptoms, all the way up to class 4, people that are unable to carry on any physical activity without discomfort or sometimes have symptoms at rest. Importantly, in difference to the ACC-AHA stage, you can move back and forth through this categorization. People can present to the hospital with class 3 or class 4 symptoms and get diuresed or get their medications optimized and go back to class 2. So people can move forward and back, unlike the ACC-AHA stages. In terms of classification by ejection fraction, so that document that I pointed out at the beginning in 2021, it really redefined the different categories for heart failure classification. So in this newest definition, they kept the same definition for heart failure with reduced ejection fraction, less than or equal to 40. However, if people improve above 40, then they're called heart failure with improved ejection fraction. And then there's one other new category, which is heart failure with mildly reduced or mid-range ejection fraction, which have EFs of 41 to 49%. And lastly, as you guys know, HFpEF is defined as an EF greater than or equal to 50. This is actually different than what many of the clinical trials have looked at, but importantly for clinical classification, this is how they define it. So you kind of initially classify people, and as I said, if people improve, then they can be kind of categorized in terms of the improved EF, which can happen on serial assessment. In terms of how to diagnose this, to put this all together, so kind of using the idea that heart failure is a clinical diagnosis, you assess the patient using the history, the exam, EKG labs, and you combine that now, remembering that now the new definition requires corroboration with either signs of congestion or elevated natriuretic peptides, which they define as an NT-proBNP greater than 125 or a BNP greater than 35. So those are like really low, right? So evidence of structural or functional abnormality, BNP elevated, or signs that you can see of congestion. And from then you do a transthoracic echocardiogram and then classify the heart failure, as we said before. So between kind of the mid-range or mildly reduced EF to EFs less than 40 or greater than 50. And then from there, you kind of evaluate for precipitating factors, whether it's ischemic in etiology or there's other things based on their history. And then the second kind of phase is to initiate treatment, okay? Which is going to transition us to the kind of guideline-directed medical therapy or the chronic therapy, which we're going to go over what the new guidelines say, what's the evidence for that, and then kind of give you some bottom line answers on how to use this in your practice. In terms of the guidelines, just to refresh everybody, they give recommendations on for everything from class 1 to class 3. Just simply put, class 1s are green light, things that should be performed on all patients. And class 3, importantly, are the ones for our residents that should never be done. So no proven benefit or evidence of harm. And those are really the ones that get tested on your boards the most, the class 1s and the class 3. Class 2A and 2B are, a little bit more kind of user preference or kind of, it could be reasonable in certain situations. And we won't spend a lot of time going over those, but we'll give you some context whenever that would be important. So here is a slide that we're going to go through all the details. So don't worry about kind of memorizing everything now, but I just wanted to give you guys some context about where we've come in terms of, we have the newest set of guidelines in 2022, but just take us back 10 years. What did the old paradigm look like before we got there? The last set of guidelines, the full set of heart failure guidelines were published in 2013, and this is what it looked like. In terms of all patients, they were on beta blockers, ACE inhibitors, ARBs, and then spironolactone and a variety of other kind of medicines and device therapies based on their symptom category. That old paradigm, maybe like 5 years ago, was disrupted with the advent of sacubitril valsartan or Entresto, which really came to really challenge ACE inhibitors and ARBs. And we've gone through various updates to the guidelines before we kind of settled in this last set of guidelines, which updated everything. So as we go through and understand how we got here, it's important to just kind of understand a little bit about the pathophysiology of why each of these therapies have kind of biochemical and neurohormonal mechanisms in which they impact heart failure. And then we'll talk about the evidence for how they actually work on patients. So the current paradigm, you can see, kind of involves the neurohormonal system, where the sympathetic nervous system is one that's kind of tightly regulated and can be disadvantageous in heart failure as people get worsening cardiac contractility. That there's compensation through kind of the endogenous catecholamines, adrenaline, noradrenaline, that lead to vasoconstriction, chronotropy, increased inotropy, increased activity of the renin, aldosterone, angiotensin system, and secretion of vasopressin. All things that are good in the short term, but can lead to longer term deleterious effects. Similarly, the RAS system is one that also causes vasoconstriction, but also, in addition to many of the same things that the sympathetic nervous system does, it also leads to kind of hypertrophy, fibrosis, and increased secretion of aldosterone. So kind of going through each of these kind of systems one by one, and we'll start with kind of beta blockers. So what does the guidelines tell us about beta blockers? So beta blockers are a class 1 indication for all patients with current or prior symptoms of heart failure with reduced ejection fraction, and specifically the agents of bisoprolol, carvedilol, or the sustained release metoprolol or metoprolol succinate. A quick review of what some of the trials are. I'm not going to go through every trial, so don't worry, don't freak out. This is not going to be one of those talks, but just to give you guys context of how we came to that class 1 indication. So through a variety of populations over the late 90s and early 2000s, we showed that beta blockers in less sick patients and really sick patients, NYHA class 4, ES less than 20, and post myocardial infarction patients, all led to significant reductions in mortality. Significant reductions in mortality. So you can see kind of 20 to 40% mortality reductions based on the use of beta blockers. So so you could see kind of how beta blockers came to use. Skip past this slide. So really you can understand how it really led to a class 1 indication. In terms of the second system that we're going to talk about in terms of the neurohormonal cascade here is the RAS system. So RAS inhibitors, so ACE inhibitors, ARBs, mineralocorticoid antagonism were the focus. So the old paradigm from the 2013 guidelines put ACE inhibitors as a class 1 recommendation for all patients with HFrEF with current or prior symptoms. Angiotensin receptor blockers were used in patients that couldn't tolerate ACE inhibitors, but that, that was the primary kind of use for it. And important to note that combining ACE and ARB and aldosterone antagonism was a contraindication. So that's what the old guidelines said. And how did they get there 10 years ago? Well, they used data over the 80s and 90s that showed, again, that ACE inhibitors save lives in really sick patients, less sick patients, asymptomatic patients, post-MI patients. Every category of patients, there were significant reductions in mortality. So ACEs save lives. Similarly, ARBs, when compared to placebo, had significant reductions in all-cause mortality, heart failure, hospitalization. So things that just give you context on how ACEs and ARBs became the mainstay of therapies. Now going back here, we understood that there existed this other kind of element of the neurohormonal system, the natriuretic peptides. And natriuretic peptides, were important to kind of counteract some of the neurohormonal, maladaptive things of the RAS system, as well as the sympathetic nervous system. It really led to vasodilation when natriuretic peptides were around. It led to, decrease in hypertrophy and fibrosis and kind of promotion of diuresis and natriuresis. So really kind of things that are advantageous in heart failure. So, kind of the theory made sense that increasing natriuretic peptides could help heart failure patients. But, we tried about 15 years ago to try an agent called nasiratide. Nasiratide was an IV infusion. You guys might not remember it. I think it kind of came out in the early 2000s, and it was in a large New England Journal kind of publication that, there was a lot of hope for it, but it didn't work in kind of a multi-center trial. And so there was a kind of a reframing of whether natriuretic peptides are really the answer. And, people felt like maybe nasiratide wasn't effective because it was a continuous infusion of synthetic BNP. But, maybe there's another way to increase natriuretic peptides, and that's by inhibiting the degradation. As you notice from the graph here, that natriuretic peptides are broken into like inactive fragments by neprilysin. So if you can block that degradation pathway, then you can increase natriuretic peptides, and that's how neprilysin inhibitors came to fruition. So they tested neprilysin inhibitors by themselves, and they didn't work. They didn't really show the impact that we wanted. So the question is, if all of this makes sense from a neurohormonal and a biochemical kind of from pathways and understanding the physiology, why doesn't it work clinically? And the answer is that neprilysin, the enzyme, doesn't only block degradation of natriuretic peptides. It also degrades several other substances like substance P, angiotensin 1 and 2, bradykinin, endothelin 1. Thus, although the inhibition of neprilysin would increase levels of natriuretic peptides and other compensatory peptides, leading to kind of the desirable effects that we've talked about, there are also increased levels of peptides that yield an undesirable effect, such as vasoconstriction related peptides of angiotensin 2 and endothelin 1. So it can actually cause adverse remodeling that really counteracts the benefits of the natriuretic peptides. So then the question was, why don't we combine neprilysin inhibitors with an ACE inhibitor? So you would inhibit the bad stuff while getting the good effects of the increased natriuretic peptides. That's bad because neprilysin also degrades bradykinin. So neprilysin inhibitors increase bradykinin, leading to higher chances of angioedema. So you really can't combine them together, neprilysin inhibitors and ACE inhibitors. So the next step, kind of in logical thinking, was why don't you try it with an ARB? And that's how we got to ARNIs, which you can kind of see there. as the next therapeutic target. So this is one trial that I do want to kind of go through in some detail with, just because it does impact our practice pretty significantly, and that's the Paradigm HF study. So this is going to be a couple slides quickly going through kind of what the trial looked like. So importantly, large trial, multi-center, nearly 8,500 patients, all low ejection fraction, with some clinical sign or symptom of heart failure. So either they've had a heart failure hospitalization or they've had evidence of elevated natriuretic peptide. And what it looked at was Entresto, or sacubitril valsartan, versus enalapril. So the gold standard of the day 10 years ago, I said, was the ACE inhibitors as kind of your first line. So it was really comparing first line versus a new agent. So really kind of a well-designed study. And you can kind of see that people were on much of what we expect in terms of guideline-directed medical therapy, high rates of beta blocker use, and aldosterone antagonism. What the outcome of the trial showed was that there's a dramatic reduction in cardiovascular death, a 20% relative reduction, or a 4% absolute risk reduction, and there's a 3% absolute risk reduction of heart failure hospitalization. And that was over and above what we'd already known as really dramatic effects from ACE inhibitors in eras prior. So that's what led to, so that trial is what led to the FDA approval, and it reduced the risk of cardiovascular death and heart failure hospitalization in patients with chronic heart failure and reduced ejection fraction. The dosing, the lowest dose range is 24-26. The kind of start dose for people that are already on a moderate dose ACE inhibitor is the medium dose 49/51, and the maximum dose is 97/103. And just so you guys understand, I thought this was interesting. The reason why there are weird doses like this, 97/103, is that the FDA mandates that you can't have combination pills with the same dosage number. So it couldn't be like 100. It had to be, they had to be slightly different. And then the side effects really were hypotension, which you'll have with ACE inhibitors, but you get less hyperkalemia and renal dysfunction than you do with ACE inhibitors. But importantly, as we kind of talked about the pathophysiologic mechanism, or the mechanism by which it works, it inhibits the breakdown of natriuretic peptides. So therefore, checking a kind of BNP is not accurate. You really must check an NT-proBNP, because that's the precursor to BNP and not subject to neprilysin inhibition. So that really led to a kind of a paradigm shift based on the Paradigm HF trial. And this new paradigm really set up as ARNIs as the way to go, as kind of the first line choice. And that's reflected in the 2022 guidelines for all patients as a class 1 recommendations with chronic heart failure, NYHA's class 2 or 3. And that it's important that this newest set of guidelines actually says that patients that are on ACE or ARB, they should be replaced to an ARNI to further reduce morbidity and mortality. So really just understanding that ARNIs are superior to ACE inhibitors and ARBs. But it's importantly a class 3 guideline, and just in terms of practical administration of it, to not mix ARNIs and ACE inhibitors together because of that increased risk of bradykinin and angioedema. So you must wait 36 hours from the last dose of ACE inhibitor, and that they shouldn't be administered in any patient with a history of angioedema. In terms of what ACE inhibitors and ARBs have been left with, is that it's really for patients that have heart failure with reduced ejection fraction, symptomatic heart failure, that ARNI is not feasible. And oftentimes in the populations that we take care of patients, that's usually like at county, when it might not be as easy from a pay perspective, although it is now on formulary there, and most insurance companies now kind of pay for it, even Medi-Cal. So it should really be the standard choice. The newest kid on the block, I'm sure you guys have had many talks about SGLT2 inhibitors, are almost sick of it by now. but they are really remarkable in terms of their impact on our patient population. And they really open the door across a wide range of ejection fractions in terms of really favorable outcomes. The first really trial that really showed a profound benefit was the DAPA-HF trial, which looked at Farxiga or dapagliflozin in patients with heart failure with reduced ejection fraction, regardless of diabetes status. And really, it enrolled symptomatic heart failure patients with low ejection fraction and a large patient population, nearly 5,000 patients, and it showed nearly 25% kind of composite outcome difference of death, hospitalizations, or urgent heart failure visits, but also showed some favorable secondary outcomes in terms of just overall cardiovascular death and worsening of renal function. That's led to the DAPA-CKD trial and some other DAPA and renal dysfunction trials that have demonstrated that it improves renal outcomes, and as well as kind of some meta-analyses that have shown across a multitude of trials that SGLT2s have a reduction in cardiovascular death across all ejection fraction ranges. So really the conclusion here is that DAPA had a really impressive reduction in CV deaths and heart failure events, and that's led it to be a class 1A recommendation in patients with symptomatic heart failure with reduced ejection fraction to reduce hospitalizations for heart failure and cardiovascular mortality, importantly, irrespective of the presence of type 2 diabetes. So, there was a lot of concern early when SGLT2 inhibitors came out that this wouldn't be prescribed because they'd have to be sent to endocrine and stuff like this. I think as it's kind of gained acceptance and become really a pillar of heart failure, it's something that I prescribe on a daily basis. And I think you guys would probably have more experience also prescribing. So, really kind of part of the guidelines now. In terms of aldosterone antagonists and thinking of things like spironolactone, eplerenone, it's a class 1 indication based on US guidelines for heart failure with reduced ejection fraction and symptomatic heart failure. And specifically, the kind of things to watch out for are people with renal dysfunction. The newest guideline kind of sets out an eGFR of greater than 30 and a serum potassium as less than 5 is what you need to show before initiating therapy. Similarly, there's a separate category for patients with acute MIs who have either an LVEF less than 40 and heart failure symptoms or have a history of diabetes. So regardless, people with low EFs should be getting on aldosterone antagonism too. And we'll talk about the class 3 here, kind of a recommendation, which is do not use in patients with hyperkalemia, especially those that can't be maintained on a potassium less than 5.5. And that's based on some of the trials that have shown that, in rails and Ephesus, that both spironolactone and eplerenone lead to significant reductions in mortalities. But observational studies that have shown higher hyperkalemia hospitalization and higher rate of hyperkalemia related deaths, small numbers, but kind of significant kind of potential harm if not kind of monitored appropriately. Moving on to Iserdil and hydralazine. So these are agents that are also been supported in the guidelines for several decades. It's a class 1 indication in patients that are African American based on the AHEF trial with symptomatic heart failure that are already on optimal therapy with ACE inhibitors and beta blockers. So importantly, these are patients that have been optimized by ACE inhibitors, ARNI, kind of extrapolated, and beta blockers kind of on optimal doses before you introduce this medicine. The 2A recommendation is people that for a variety of reasons that cannot tolerate ACE or ARNI, that there's Iserdil or hydralazine used as a afterload reduction tool, but it doesn't have quite the same evidence base to support it. So this is again to show Iserdil and hydralazine in kind of a variety of trials over several decades that showed that it reduced mortality, reduced hospitalization, increased quality of life. The AHAF trial showing that in specifically the African American population. Bottom line is that when it was compared to ACE inhibitors, it's not as good in head-to-head comparison, but it's useful in kind of specific populations, specifically African Americans. And the reason why African Americans benefit disproportionately is not really clearly understood, and that we do use it as kind of a replacement in people that have contraindications to RAS inhibition, but really there's very little data to support this practice. It's just something that kind of intuitively makes sense, but hasn't been kind of proven in any real way. So going back here to our old paradigm and now updating it with the paradigm shift that happened with Paradigm HF trial for Entresto. You see here kind of the purple that ARNI is now supplanted ACE inhibitors and ARBs, and now is kind of your first line therapy through all kind of symptom classes, along with beta blocker. And that in symptomatic heart failure, now we have the addition of SGLT2 inhibitors to spironolactone and isodenone hydralazine as well. Now going to device therapy. So what do the guidelines say about that, and what's the evidence for those? So what's the evidence for implantable defibrillators? So the guidelines say first is class 1 recommendation, and people that have had a VT or VF arrest or have had a sustained VT. In patients that, as you guys know, have EFs less than 35, non-ischemic or ischemic. That's probably the most important kind of thing to remember, EFs less than 35. And importantly, in ischemic patients, that's at least 40 days post-MI. And the class 3 recommendation is that if there is frailty or other comorbidities that limit survival with a good functional capacity to less than 1 year, the guidelines do not support the use of ICDs. What does the studies tell us about this? It tells us that there's a significant reduction in mortality and arrhythmic deaths from using ICDs. And many of these trials happened in the 2000s, whenever there was a good regimen of guideline-directed medical therapy, beta blockers, aldosterone antagonism, ACE inhibitors, but not ARNIs and not SGLT2s. And the bottom line is that it's still indicated if EFs are less than or equal to 35%, and you've had an MI more than a month ago, or non-ischemic cardiomyopathies, generally greater than 6 to 9 months, and that you're expected to live more than a year. One question I get a lot is if you guys are familiar with LifeVest or wearable defibrillators, what's the data for that? There isn't any data. There's no randomized control trials. There's some observational studies that have shown that it does its job, but there's nothing to clearly define a mortality benefit compared to doing nothing. And for that reason, based on the 2017 kind of rhythm guidelines, it's a class 2B recommendation. So it could be used and may be beneficial. Cardiac resynchronization therapy. If you guys are familiar with this, just to kind of take like a 1,000-foot view of what it is, for maybe our residents that haven't seen it as much, but basically the idea behind cardiac resynchronization therapy is that as people's myocardium gets more diseased and dilated, that causes disease of the conduction system. And what you see most prominently is the development of a left bundle branch block. And how that kind of manifests from a mechanical perspective is that as electrical current gets sent down from the AV node through the bundle of His and down the each bundles to the left and right bundle, those don't depolarize at the same time because there's a bundle branch block on the left. So on the right, it depolarizes, contracts the kind of the right side, and then it spreads through kind of gap junctions through electrical signal and Purkinje fibers and all those things you guys remember from medical school to actually contract the left side. And so what we've seen through a variety of studies is that non-synchronized contraction leads to increased in LV dilation, decreases in ejection fraction, decreases in RV function, increases in mitral regurgitation. So really kind of profound remodeling things happen whenever cardiac contraction is not synchronized. And so for that reason, guidelines have supported the use through a lot of clinical trial data that we'll go over, the use of cardiac resynchronization. Basically what happens there is our electrophysiologist put a lead into what's called a coronary sinus, or the vein that runs under the heart, into the lateral side of the left ventricle, so that they can stimulate the electrical currents on the left side of the heart, so that they can time it up and basically resynchronize electrical and thus mechanical contraction of the heart. It's a class 1 indication for patients with ejection fractions less than 35% and symptomatic heart failure. Patients are in sinus rhythm, left bundle branch blocks with QRS durations greater than 150 milliseconds. The class 2A recommendations are generally the same, except that it says that it could be beneficial in people that have wide QRSs that have non-left bundle branch blocks. Either they have interventricular conduction delays that are not pure left bundles, or they have right bundle branch blocks. And then similarly, people that have QRS durations of 120 to 149 milliseconds, but have a left bundle branch block, could also qualify. Anybody that has QRSs less than 120 are not candidates for cardiac resynchronization therapy. And so what is the data? You can see that there's a lot of trials over the last 2 decades that have shown improvements in quality of life, decreased hospitalization, decreased death rates, all-cause mortality, decreased heart failure events in a variety of populations, NYHA's class 1 to 3, and people that had the least benefit, you can see here, are people that have narrow QRSs. So those are some of these other trials that were less positive for CRT. So really the bottom line here is that it does help symptomatic patients with heart failure feel better and live longer, and can lead to some positive remodeling effects. And that's also seen in patients with little or no symptoms of heart failure. The research that is still yet to define is how do we define the dysynchrony that cardiac resynchronization is trying to do. Is that best defined by EKG? Is that best defined by echocardiographic parameters? And then how do we optimize resynchronization therapy? Those are kind of questions that remain, but something that the evidence tells us should be done in kind of symptomatic heart failure patients. All right, so now that we've kind of gone through kind of the mainstays of therapy for heart failure with reduced ejection fraction, I just want to go through how the guidelines tell us to initiate these therapies and layer them on top of each other. And then lastly, when to think of advanced therapies, heart transplant, LVAD, the like. So the first step of guideline-directed medical therapy initiation is to start the 4 pillars of guideline-directed medical therapy. So what we've gone over already: beta blockers, angiotensin receptor neprilysin inhibition, so ARNIs, MRAs, aldosterone antagonism, and SGLT2 inhibitors. And you can see those are all class 1 indications for people with heart failure with reduced ejection fraction or stage C heart failure. In terms of how to initiate it, there isn't kind of clear guideline on how to do it, but the thing that's got the most press and what most heart failure cardiologists are doing is what's called rapid sequence initiation of guideline-directed medical therapy. So what does that mean? Basically, it's the idea that we need to start all of these 4 pillars of heart failure therapies early and up-titrate them quickly. So the proposed mechanism to do that is on day 1, you initiate all 4. You initiate ARNI, beta blocker, MRA, SGLT2 inhibitor. And then every 2 weeks, you'll notice that you first double your beta blocker. and then you start doubling your Entresto, though. So that by about week 6 or day 42, you have patients on kind of the maximum tolerated doses of all of these medicines. And you can kind of see that the relative risk reduction and mortality for each of these medicines is pretty profound. And so together, if you add them, you have a net relative risk reduction of about 75%. But also you can see those, and the reason why it's been proposed to do it rapidly and early is that there is really early and profound improvements in hard clinical endpoints for patients. So you'll kind of notice here that for each of these medicines, ARNI, beta blocker, MRA, SGLT2 inhibitor, on the left, you'll see that there's been data to show that there's early relative risk reductions in everything from cardiovascular death to all-cause mortality to kind of composite endpoints. Namely, if you just look at one of those, the 58% relative risk reduction in death, heart failure hospitalization, emergency or urgent care visit for worsening heart failure, 58% relative risk reduction that's seen within 12 days of therapy. So 12 days after starting SGLT2s, we've seen a reduction in these composite endpoints. So really remarkable early and profound improvements in outcomes. So really that's where some of the leaders in our field are advocating for early rapid sequence initiation. And just to kind of beat this nail in a little bit is just looking at all of these therapies. There's such marked improvements in survival, number needed to treat as low as 6 for aldosterone antagonism, spironolactone, up to 26 for ACE inhibitors, to number needed to treat for all-cause mortality over 36 months. So really kind of profound effects. And all of these effects are actually additive. You can see in this kind of nice illustration as you kind of go up from placebo all the way to the top there, which is the quadruple therapy of the kind of 4 pillars of heart failure. You really get additive effects as you add one on top of the other. And really the best efficacy lies when you combine all of these therapies together. So kind of just going through, so that's just really how you titrate to target dose, kind of that rapid sequence initiation that I went through, and these are the target doses kind of written here. So Entresto is that full dose, 97 over 103 twice daily. Carvedilol is probably the one that we use the most often. It's 25 to 50 milligrams twice a day, based on their weight, is what determines kind of whether you can go up to the 50 milligram. And metoprolol succinate, it's important that 200 milligrams is the goal dose. Spironolactone, which is the one that you probably use the most, is 25 to 50 milligrams. And then SGLT2s are easy. You just start them and the MRAs together, and they don't have a lot of titration to them. After you kind of get patients on their goal doses, you really consider specific kind of adjunct therapies based on their specific patient scenarios. So, in terms of African Americans, you think about hydralazine and nitrates, or if they're already maxed out on the other GDMT and they have blood pressure room, then you add those on. We talked about defibrillators and CRTs in the right patient populations, and there's some other medicines that really are kind of confined to the heart failure space that you can consider, but really aren't used widely. And those are medicines that you might have heard of, like Avabradine, Vericiguat. Those are kind of medicines that I've honestly used a handful of times, but are available and FDA approved. The last steps are kind of advanced heart failure referrals. So if patients, as you kind of layered on these therapies, kind of starting with your pillars, your 4 pillars, kind of getting them to goal doses, people are still symptomatic after defibrillator, CRT, and the addition of hydrols and nitrates, and have really kind of refractory symptoms, then you really have to think about kind of sending them along for advanced therapy or heart failure specialty care. So where we can consider patients for cardiac transplant, durable mechanical support, or if they're not candidates for either, really talking to them about goals of care and whether kind of transitioning their goals to more comfort-based measures with home palliative care can be really effective. Or kind of offering investigational studies at kind of larger centers. So what are some of the triggers for kind of referral to an advanced heart failure specialist like myself? The ACC-AHA, kind of our professional societies, came up with this mnemonic to help identify patients that really meet high risk clinical risk factors for poor prognosis. Okay, and that mnemonic is "I need help." Like any mnemonic, it has its good ones and its less good ones, but some clear ones that really stand out are IV inotrope necessities. So people really, when they go home with IV inotropes, they should really get referred to an advanced heart failure specialist. If you guys are ever, I'm sure you're probably not discharging a lot of people on home inotropes, but really they should be seen by heart failure specialists, or at a minimum, if they're not a candidate, kind of referred to palliative care. The N is for high NYHA class, meaning really significant symptoms or functional limitation or persistently elevated natriuretic peptides, the presence of end organ dysfunction, really any ejection fraction less than 35%, kind of noting more severe heart failure, the presence of defibrillator shocks, hospitalizations, which I'll talk a little bit about in detail with that. Edema despite escalating diuretics, meaning that you're kind of failing therapies and having persistent congestion. Low blood pressure, high heart rate is just saying that patients are maximally compensated physiologically, and so they might need additional help there. And then prognostic medication, I really like progressive intolerance. So if you're finding yourself having patients that have been steady on guideline-directed therapies for a while and suddenly stop tolerating them as much and you're coming down, that should be really a trigger in your mind that people are not really able to do well. I see, sorry, I'm just seeing a question. Initiating 40 medication at one time seems like high risk for older adults who may already be on several prescriptions for other issues. What do we know about the side effects, downside about early rapid sequence initiation, especially for people over the age of 80? Really great point. And it is true that as people get above an age of 75, the advocates for rapid sequence initiation say that might not be the patient population to do it in. So in those patient populations, you really have to be more careful because of kind of risk of falls, etc. So, but kind of in all comers, my heart failure practice is pretty heterogeneous, and so I'm seeing people of all different ages. But you are right, Dr. Mosqueda, that kind of older patients really kind of represent somebody that you have to really think about whether rapid sequence initiation is the right idea. So I told you that we'd kind of talk about a couple of these factors that are kind of clinical risk factors, specifically NYHA class and hospitalization. So the role of NYHA class in predicting mortality risk. So, kind of intuitively makes sense. If people feel worse, they're probably going to do worse. But there's data to support this. In fact, people that have the most severe symptoms have a nearly 30% increase in all-cause mortality. So really, so it should represent something in your mind that as people are starting to feel worse, that those are people that should be getting kind of, advanced heart failure specialty referral. And then lastly, hospitalization. To me, this is the most important one because if you just think about how many of your patients with heart failure have been in and out of the hospital, they feel bad, they go into the hospital, they feel better when they leave, but there are changes that happen from a remodeling perspective that really, and potentially a biochemical perspective that really kind of reflect that patients do worse after they're hospitalized, regardless of how they feel when they first leave. And you can kind of see here from this graphic table that with patients' first hospitalization, they have about a 2.5-year median survival from that. By their fourth hospitalization, when you're discharging a patient from their fourth hospitalization, you have to think about a median survival of about 6 months. So really people that have profound kind of limitations on their life. And for that reason, kind of the triggers for referral to an advanced heart failure specialization is just more than one hospitalization. So, just it's one thing that, I think was new to me. And oftentimes when I give this talk, is surprising to people because we have some patients, particularly at county, that are like in and out of the hospital, and we don't really think about their prognosis in this way. And so why is it important to kind of send these patients on to advanced therapy kind of consideration and advanced heart failure specialist consultation? Is because we can offer them something that can dramatically improve their lifespan, and that's heart transplant. And this is my only slide on heart transplant, but it's just to say that in every era of heart transplant since the 80s, and even prior, we've had approval and survival with every era. And median survival now in the current era is about 12 and a half years, which is much better than end-stage heart failure. So there is something that we can really do in the right patients, intervene and offer them something life-saving. And the cool thing is that things like LVADs, durable LVADs, have very similar now comparable survival to heart transplant. So, come with some downsides. Obviously, they have a pump with an external drive line and all this stuff. But generally, if they want to feel better and live longer, it's something that can really be powerful for many patients. And that there isn't necessarily an age range on that. There are certain centers that are doing LVADs and people in their 80s at UCSD. We're doing LVADs and people in their kind of advanced in their 70s and stuff. Whose really only comorbidity is heart failure. So it can have powerful effects. So to put this all together, is thinking about all of it, kind of across different functional class, that there's patients that will benefit with kind of your quadruple therapy of beta blockers, ARNI, SGLT2s, and spironolactone. You combine device therapies and then some adjunctive treatments, and then really thinking about the most severely symptomatic patients, referring those people on so that people like me can consider them for advanced therapies, hospice, investigational therapies, or other kind of devices that we not have time to talk about, like MitraClip. So last kind of piece is just a couple slides on some of the new recommendations for heart failure with mid-range EF or mildly reduced EF and heart failure with preserved ejection fraction. So as a reminder is that these are patients with the mildly reduced group that have EFs of 41 to 49. For many years, we didn't really know what to do with those people. Now we have a little bit more guideline acceptance for basically all the therapies that HFrEF kind of patients get, but with a particular emphasis because the data is actually greatest for SGLT2 inhibitors in this patient population. So that's a 2A recommendation. But with the most recent trials in the last several months, it would probably in the newest iteration be upgraded to a class 1. There's been several more trials that have demonstrated benefits in survival as well as heart failure hospitalizations. And then similarly, ARNI, MRA, and evidence-based beta blockers, realizing that people on the lower end of ejection fractions are going to probably derive the greatest benefit from all of these therapies. In terms of heart failure with preserved ejection fraction, as you guys know, there's not been any therapies for decades that have shown a significant benefit in this patient population until SGLT2s came around. And like I said before, there's been kind of across all ranges of EF, with or without diabetes, a variety of positive outcomes, everything from hospitalization to deaths from cardiovascular causes. The DELIVER trial is the one that used DAPA and showed an improvement in cardiovascular mortality. And meta-analysis have again showed that. So this is Emperor Preserved, which is looking at empagliflozin or Jardiance in this population, and again, kind of a positive trial. So that's what the guidelines tell us, is that it's a 2A recommendation, but you can similarly combine Entresto, MRAs, into that category too, in select patients. And there's an FDA approval for that as well, FDA approval for ARNIs across EFs. So what are the takeaway messages? My last minute here is that GDMT for HFrEF now includes 4 medication classes that have been shown to dramatically improve survival, symptoms, heart failure hospitalizations, and quality of life. And that combining these therapies with device therapies has oftentimes additive effects. SGLT2s have a class 2A recommendation and mildly reduced EF. Weaker recommendations are made for the other classes of guideline-directed medical therapy, and there's a new recommendation, as I said, for SGLT2s and heart failure with preserved ejection fraction. Lastly, something I didn't cover, but just an important note to make, heart failure with improved ejection fraction, I kind of mentioned as a new category of people that had previous heart failure with reduced ejection fraction, but now recover and have an EF greater than 40. There's been one major trial, the TREAD-HF trial, that says that you should really continue these patients on their heart failure with reduced ejection fraction therapies. So just because people improve doesn't mean that you could take them off these therapies. These are generally should be lifelong therapies unless there's a very clear reversible cause, like thyroid issues or something like that can be reversed. And then lastly is that advanced heart failure referrals should be considered early for assistance in management, optimization, consideration of advanced therapies, given the enormous benefits and quality of life and survival. I didn't present this data, but really thinking about those advanced heart failure patients have about a 25% 1-year survival and an 8% 2-year survival. And with heart transplant, we can offer kind of nationally 90 to 95% survival 1 year. At USC, we have about 98.4% 1-year survival. So really kind of remarkable what you can offer these patients. I appreciate you guys giving me the opportunity to speak to you. And as always, I'm kind of available as your colleague if there's anything that I can help you with outside of this talk. I'll open up for questions if anybody has any.
Thanks so much, Ajay. Thank you, Dr. Mosqueda, for your earlier question. And does anybody else have any questions? Feel free, you can unmute or type in the chat. I think I have a couple of questions while everyone else thinks about it. There does seem to be there's a little bit of data for subsets of our population. You pointed out specifically the Iserdyl hydralazine option that might be preferable in African-American patients. It always strikes me practicing here in East LA that, we don't have a lot of data on other ethnic minorities. Do you know if anything else other than this data exists in African Americans, i.e. other populations, or if there's anything in the works to identify targeted therapies for specific populations?
Not based on racial categories, so no, or at least not nothing I know of. I think it kind of reflects to me a broader kind of concern across all clinical trials. If you notice, clinical trials, at least in the cardiovascular space, but I'm sure it kind of extends beyond this, are generally white males, kind of greater than 70% of kind of higher socioeconomic categories. So we don't have great data for any of the things that we're talking about in females, in minority groups, and people of different kind of socioeconomic statuses. So
yeah, good point. Question. Females always get left out of much of the crowd too. So definitely future pursuit of more data there. My other question, this is largely anecdotal, I feel like, but in terms of beta blockade use, certainly for patients with coronary artery disease, so ischemic cardiomyopathy, obviously beta blocker itself is not controversial, and we kind of have it narrowed down to a few, but one of the subtexts there is actually controlling heart rate, not just having a beta blocker on board. And I tend to use a lot of carvedilol, but this is the anecdotal part. I feel like maybe it's less of a strong chronotrope, and I don't know how to reconcile that with the desire to lower the heart rate significantly.
Yeah, great question. And I'll just tell you my practical, like, so generally, in terms of beta blockers, I think that while there's never been kind of a direct head-to-head of carvedilol versus metoprolol succinate, I think generally the heart failure consensus is that carvedilol is probably a better beta blocker in terms of achieving kind of those endpoints. That's probably because it's non-selective, right? You get alpha as well. And so for that reason, and, the previous trials of the co-reg trials in like the mid 90s kind of showed an absolute benefit that was actually greater than the metoprolol succinate trial. So I think as a beta blocker, I think co-reg is probably better. But but I still use metoprolol succinate, and I think the people that I use metoprolol succinate in are exactly the patients that you're talking about. People that have a lot of arrhythmias, need heart rate control, or people that have soft blood pressures. And that's because it doesn't have that alpha effect. So you get less of in my experience, less of a kind of blood pressure lowering problem. So if you need to uptitrate to the beta blocker, so you're getting more pure beta blockers. So if you need to uptitrate it for either people that are having a lot of ventricular arrhythmias, or having kind of high heart rates that you want to control, you're going to get more bang for your buck, as you said, in terms of the beta block, which is going to be the kind of the chronotrope, a negative chronotrope effect, than you are with co-reg, because as you go up in the co-reg dose, you're going to get probably equivalent beta blocker coverage, but you're going to come at the cost
more
of
antihypertensive effects. Okay, great. Thank you for clarifying that.
Yeah.
Okay. Excellent. Any other questions from the audience? Thank you so much, Dr. Vaidya. That was a fantastic, comprehensive, efficient talk with lots of great evidence basis. Great job. Thank you.
Yeah, my pleasure, guys. Feel free to reach out if there's any questions. It's always great to talk to you guys. Thanks, Jennifer, for having me.